Point in Question, a weekly public affairs program. And now your host, Dick Deason.
Hello, and welcome to Point in Question. Tonight's guest is Dr. William R. Willard. Dr. Willard has recently retired from his post as Dean of the College of Community Health Sciences at the University of Alabama. In his tenure there and as Dean at several other university medical departments across the country, he's built a tremendous reputation as a medical educator. He's been one of the main generators of the concept of family medicine. He is, in short, an accomplished professional in the field of medical education and public health. On June 30th of this year, Dr. William R. Willard stepped down as Dean of his department. He now plans for an enjoyable retirement practicing the hobby and business of catfish farming. He's married to Adeline Willard, a lady to whom he gives much of the credit for his success. In May of this year, we visited Dr. Willard at his catfish farm in Moundville, Alabama. He talked with us about his retirement and his successful career. But before we hear from Bill Willard, let's take a quick look at his years before coming to Alabama. Upon graduating from Yale University in 1934, William Willard began work with the Maryland State Health Department. Then came World War II. He joined the Army's Public Health Service branch, where he was trained for the invasion of Japan. Upon Japan's surrender, he was sent instead to Korea, where he served as head of the military government's Department of Public Health and Welfare. After his discharge, he was offered a position at Yale with the Department of Public Health. After 5 years at Yale, spending some time as assistant dean, he received an offer to become the dean at Syracuse University. At the end of another 5-year period at Syracuse, he left to start a new school of medicine at the University of Kentucky. While serving at the University of Kentucky, he built quite a medical complex and was within a few years of retirement when he received a telephone call from a former co-worker at Syracuse. Point in Question's Tony Giles talked with Dr. Willard about the consequences of that phone call.
Why did you come to Alabama? You were a couple of years from retirement at Kentucky. You had the world on a string. You had built a very important medical complex there. Did you see something unique in the plan, in the need in Alabama?
Well, there were several factors. You're right, I was nearing retirement at Kentucky, and one begins to wonder what you're going to do. And I just couldn't see myself sitting around Lexington, maybe writing a few papers and doing whatever it is people do. And a little earlier, I'd read an article about catfish farming, and I know farmer, I knew not a thing about it, but it sounded kind of, so it might be fun and interesting, so we took a summer vacation. We toured catfish farms, we went to processing plants, we went to experimental stations, we went through Arkansas, Mississippi, part of Texas, Alabama, and well, this is what we'll do. Then we started looking around for some land. About that time, Howard Gundy, who was then academic vice president, gave me a call. Howard had been on the faculty of social work at Syracuse University when I was there, and we knew each other, and he remembered me and asked if I'd come down for a consultation visit. I wasn't very sure what the consultation was about, something to do with medicine, but it was a little hard to be clear on the telephone, but I agreed to come. I guess I'd been here 10 minutes when I figured out they were looking for somebody. In the course of time, it turned out they offered me a job, but I made it very clear. You know, I've only got a couple of years, and I'm interested in a catfish farm. During the course of the discussions, I asked the president how much money he had to launch a medical education program. He said, well, the legislature appropriated $435,000. I said, well, that's good startup money, but that won't get you very far. He says, well, it is just startup money. I said, well, will the governor tell me this? He said, well, we'll see. The next day, we were on the plane from Montgomery with the president who picked up two of his and Governor Wallace's friends, one of them being Victor Poole, our local banker. And on the way down, he says, you know, we might have some property in Moundville that would interest you. And so after we'd had our conversation with Governor Wallace, which went quite well, I went down to Moundville and took a look. I persuaded Alan to come down and my wife could come down and take a look. And after pondering a bit, we decided we'd come.
That was 7 years ago, so you thought you only had 2 years left of active service in academic medicine, and you added 5 to that.
Well, that's right. Retirement age was 65 at Kentucky. I assumed it was the same here. I wasn't smart enough to ask the question, and the President Matthews didn't volunteer any differently. And I guess it was 3 months after I'd been here before I discovered that the 65 didn't apply, and somehow I've been on the job now almost 7 years.
But they have been 7 rather pleasant years, haven't they? Could you trace the development of your College of Community Health Sciences?
Yes, in many ways. This has been the most difficult of the jobs I've had, but at the same time, I think it may be one of the more rewarding ones, because I think we have an opportunity to make a significant impact on an important social problem, and that is the health care in the smaller towns and rural areas, which the medical education establishment and really no one else much had really tried to solve. And I'll tell you, getting that college organized in the early years was one of the toughest jobs there were, because we were trying to train a new type of doctor, a family physician. There were no faculty with experience that you could recruit. You had to go out, bring in practicing physicians who weren't always comfortable in the academic world. If you went to the academic medical centers, which we've done to some extent, you get somebody with a pretty traditional orientation. So this is a very unique faculty. I thought we'd never get the first full-time faculty member, but you keep plugging along, and you get a few, and as you get them, it gets a little easier to get the next ones. And we're now to the point where 5 or 6 more positions, and we'll have a pretty well-balanced, rounded complement. We've got a good chance of doing that by summer, and I think I will feel at that point that I've created something here that's got the manpower and got the organization, got the momentum, and got the philosophy that if the right person comes along, it can go forward. If I'd stopped after 2 years, there'd been very little here.
In the early 1900s, when folks in the small towns and rural areas were sick, they could count on the wise old country doctor to cure most of their ailments. We've all heard stories about or experienced firsthand the house calls made by the family doctor. We envision that weary but determined individual sloshing down a muddy road in a Model T during a rainstorm to deliver the Joneses' baby, or trudging from house to house during a measles or chickenpox epidemic. We see an anxious parent sitting with a feverish child awaiting the knock on the front door that will announce the arrival of Doc Brown. Words like, "Get plenty of rest, she'll be okay," and the comforting, "I'll be back tomorrow," come to mind when reflecting on that dependable country physician. Well, there aren't any doctors making house calls in bouncy Model Ts these days. In fact, there aren't many doctors making house calls today, period. Nowadays, the sick patient pays house calls to the doctor. Medicine has become more specialized, complicated, and expensive, and the family doctor has almost become lost in the hustle and bustle of modern medicine. However, the College of Community Health Sciences at the University of Alabama, under the direction of Bill Willard, has been training a new breed of country doctors. But these new family doctors are called family practice physicians.
What is a family practice physician? There may be some folks who don't really understand that term.
Well, it's used oftentimes synonymously with a general practitioner. I'd say the family physician is the modern version, but there is a significant difference. The family physician is hopefully trained and will practice in a way that provides continuity of care, that emphasizes the family as a unit, that emphasizes prevention, rehabilitation, comprehensive care. This may be involved in a number of fields like medicine, pediatrics, minor surgery, obstetrics, and so forth. This contrasts with a general practitioner who provides episodic care. That is, when you get sick, you go to him, but the follow-up, the continuity, the comprehensiveness is not necessarily there. Now, I have to qualify this by stating that there are many general practitioners who really practice what we would call family medicine. But by and large, training programs until just recently haven't been geared to provide this philosophy and approach to care.
Along with the development of the specialty of the family practice has been the concept of community medicine. How are the individual and the concept related, and perhaps could you explain community medicine? What does that mean?
Now, this is interesting. It goes really back to my days at Kentucky. There were two things we did at Kentucky that were firsts in the United States. One was the establishment of an academic department of community medicine. The second was an academic department of behavioral science. Community medicine is often thought of by some people as public health, but it's more than that. It's really looking at the health of a group of people versus an individual. Diagnosing the community, if you will. What are its health problems, its health resources, its needs? How can these be met? How does the community need to be organized? What are the social and cultural factors that bear on disease in that community? So it's not involved really with the individual patient and his family, but with a whole group of people. And it requires some different disciplines to do it well.
Is that a further step in specialization of medicine, or is that a step back toward generalization of medicine?
I don't know that it fits in either. There is a specialty called public health and preventive medicine, for which physicians well trained in community medicine can qualify. I think it's really a bringing together, in a sense, of the medical establishment, the public health establishment, with some additional disciplines for a comprehensive view of the community. Unfortunately, historically, public health and curative medicine have been artificially separated, with public health departments emphasizing prevention and letting the practitioner take care of ordinary illness. But you really can't make that distinction because they're so interwoven.
Is medical practice becoming too specialized, or is that a necessary trend?
Both. I don't think anybody would question the importance of specialization. And the great biomedical research effort that this country made after World War II has resulted in really a dramatic change in the practice of medicine and in what physicians can do for patients. On the other hand, there have not been enough generalists, so that the family physician, the person that doesn't need the specialist, the person living in the smaller towns and rural areas, the person in the ghettos of the cities are not really getting served. So we've had an imbalance. We need them both. And I think the nation is now only beginning to attack this problem of proper balance.
Is it a problem that can be attacked through education alone?
Well, education can be an important component. I think part of the problem, and I won't say the whole problem, has really been the medical education establishment. And I don't think one ought to blame the medical education establishment, because they did really what the public demanded, and as indicated by how the tax dollars were appropriated. They were appropriated for biomedical research, which led inevitably to specialization and subspecialization. So a change in the educational pattern is one important component of the solution of the problem. And I think we're beginning to see that happen, certainly in Alabama. The College of Community Health Sciences here is one example of that change.
This matter of education, some folks have looked at the medical need as a need to educate doctors, to train physicians, but there's something more to it than that, that you've mentioned on various occasions. The whole business of patient education, healthcare management education, training support personnel such as nurses and other people who work with doctors and who can and should play primary roles in the delivery of health care. How do you feel about this whole item of a general sort of broad education for the public as opposed to the specific training of a doctor to do a job?
They're both necessary. And I think the whole allied health area to which you referred is of growing importance. It used to be, I think, around the turn of a century, there were maybe 2 support persons for every physician. Now there's 15 or 20. And there's over, I think, 150 different occupations listed under health with the federal government. Well, these are important because health is much more than a doctor problem. It's not only the support personnel to make a doctor's work more efficient, and many of these can do specialized tasks even better than the doctor can, such as the laboratory technician. But there's the question of economics, the financing of health care. There's the question of, since so much of medical care is now paid for by the government, governmental policies and regulations are an important factor. Third-party payment mechanisms are important factors. How medical practice is organized and how it's to be financed, how communities are organized. All of these things have a bearing on the problem. And unless one takes a really comprehensive view of it, one isn't going to solve the problem of the health care of the American people just by training doctors.
One problem in the training of doctors for health care in our American society is the geographic distribution of these physicians. Many medical experts feel that there's not a shortage of doctors numerically, but that the numbers are in the wrong places. For example, Alabama has about 1/3 the physicians in relation to population compared to the national average. And within the state, the distribution of physicians is poor. Approximately 80% of the doctors licensed in the last 5 years have elected to practice in the 5 major Alabama cities. One explanation for this geographic distribution problem is that the major medical centers are located in or near major metropolitan areas. Students in a profession generally tend to settle near the place of their schooling. Figures indicate that physicians usually practice within 50 to 75 miles of the place where they were trained. This matter of distribution has been a major concern to the public and members of the medical profession in the past decade. And in a larger sense, it forces the medical profession to decide whether or not it is really meeting public health needs. In one word, accountability.
Do you see this movement toward accountability as being a continuing sort of thing? And is it accomplishing anything? Is the movement toward accountability changing in any way the education of physicians and the practice of physicians?
I think it's an important factor. Medical education is often considered to be one of the most expensive forms of education. Certainly the nation is greatly concerned about the escalating healthcare costs, and I think we'll be called increasingly to task to justify what we're doing. And there are lots of efforts along this line. For example, medical audits, quality control standards, and the sort of thing that are beginning to be invoked. The necessity for recertification in a specialty in order to continue practicing or to be licensed. These are trends along that line. And I think in the case of the College of Community Health Sciences, if in 10 years we cannot demonstrate that we've had some significant impact on the health care in rural Alabama, then there's really not much justification for our existence.
If there was a case to justify the existence of medical education in this country, Dr. William R. Willard would certainly be a strong witness for the defense. He is one of the most recognized, accomplished, and respected medical educators in the nation. During our May conversation with the doctor, he discussed some of the major trends in medical education he has observed during his career.
I think there are several things that have happened. About the earliest one I can recall is really in the late 1940s. Now this is all apart from numbers of new schools and things of that sort. Was an effort at Western Reserve to break down departmental barriers and get interdisciplinary training to show the interrelationships between anatomy, biochemistry, and clinical medicine, for example. And that's had a significant impact on medical schools. The Western Reserve pattern's rarely been followed exactly, but it's had its impact. The second thing that I think is important, we've seen the development of the behavioral sciences and psychiatry as important components of the curriculum. We're now recognizing the impact of social and environmental factors and their influence on human response to illness. And physicians need to know these, and you're now finding that in practically every medical school curriculum, to some degree or to another, these elements are now being taught. The third factor is community medicine. It's a relatively new discipline. It's like new disciplines. It has many definitions, and it's going to take a while, just as it's taking with family medicine, to shake it down into a well-defined, commonly understood body of knowledge. But I think this is important. And probably the fourth thing that is happening, not very much. We've been giving this lip service for many years, but that's the team concept. How do you get the doctor to the nurse, the laboratory technician, the social worker, and the others cooperating and working together for the benefit of a patient? And unfortunately, our educational system fragments them. They rarely have contact with one another in any organized way during their educational program. And I guess the final factor, which is really part of good medical practice, is an increasing emphasis on trying to personalize care, and as well as a concern about the cost of care. Students and those in specialty training are now being asked questions about, during training, what's this procedure going to cost? What's its cost benefit to the patient? These are all factors that I think have been developing in medical education.
What are you going to do when you retire?
Well, that's what we got the fish farm for. I don't know. There may be some various volunteer or other jobs that I can do that can contribute to the cause that I'm deeply committed to in the health field and in the university, and if so, I'll give some time to that. I think I put in now, gee, it's over 40 years, full-time professional life. I really feel that as far as the college goes, it's time for some younger, some more vigorous leadership to come in, and I will not begrudge that. I'll help it in any way that I can, but I think I'll have enough to do.
If you could go back to day one, start your life, your career all over again, is there any of it you would do differently?
I don't really think so. I think, like most people, prepared for a profession, and I prepared a little differently than the average medical student because I did elect a public health training. So I brought perhaps a little different perspective. But then one takes advantages of the opportunities as they come, and I've been very fortunate in that I've had many good opportunities. There have been some that it's been very hard to choose between. But I don't look back. You make the decision, go forward, and I don't really regret any of these decisions. I think the world, although it's getting tremendously more complex and the problems difficult, the challenges and the opportunities in this field are tremendous. And if I were a youngster coming along now, exactly what I'd do, I don't know, but I think I like to fill approximately the same role of trying to provide some leadership in improving education and health services to the people.